Thank you everyone for being here today. My name is Adrienne Tillman. I'm the editor at MEAction, an advocacy organization for myalgic encephalomyelitis, also known as chronic fatigue syndrome, or MECFS, or most commonly known in our community, simply ME. So MEAction has brought together this panel of experts today to discuss how we must respond to the crisis of long COVID. At the end of the panel, we'll have a question and answer session. As you are all well aware, we are facing a crisis of millions of people not recovering from COVID-19 who are going on to develop complex chronic illnesses. One of those illnesses is MECFS. Researchers are expecting anywhere from 5 to 9 million people are developing ME following a COVID-19 infection. This is on top of the estimated 1.5 million people who already had ME prior to the pandemic. So our numbers are surging. Our first panelist who will speak to the question of how we must respond is Shamir Smith. Shamir is a beloved middle school teacher in Baltimore. She knows firsthand what it means to live with long COVID and the obstacles to seeking care, especially for women of color and the BIPOC communities who have been hit the hardest by COVID-19. Shamir now works as a consultant, excuse me, as a consultant in long COVID research, education, and treatment for Black people in urban communities. Thank you so much for being here today, Shamir.
Thank you, Adrienne. Many long COVID patients who were infected with the virus during what many of us have coined the first wave between December 2019 and March 2020 have already marked our COVID-versaries, the date that our lives changed significantly, or from speaking frankly, for the worse. Sometimes I have to ask myself, Shamir, aren't you tired of telling your story yet? Who cares that you are a former middle school teacher, a Black woman who got sick in March of 2020? Who cares? And just as I answer the question, yes, I might be getting a little tired of telling my story. A doctor will reject my diagnosis of long COVID that another doctor has given. My job decides recently to cancel my health insurance without prior notice. Another Black woman in my community in Baltimore sends me a direct message of her long COVID experience, and someone else wonders if I can recommend physicians and resources for them to immediately seek. While I joke often that many long COVID and ME patients have received their honorary yet invisible medical degrees for lending a wealth of information and support to newcomers who unfortunately have to join this society, that is no longer a secret. It's not a secret anymore. It is imperative that we, societally, federally, legally, and compassionately take risks to provide support, research, and treatment for patients who simply will not survive without these. Notably, while our white counterparts are being provided clinical trial access and medical information, BIPOC long COVID patients are finding that in urban and rural communities, the silence is raging on the cusp of a natural disaster with no water or wind in sight. Our bosses, our family members, our doctors, and our social service partners are watching as we deteriorate against the weight of delays in workplace guidance, unavailable mental health resources, unfathomable, embarrassing waiting for Social Security benefits, and so much more. People are acting like they don't get it because they don't have to live it. But I believe that they can start getting it right now. It is imperative that our local, state, and federal governments crack open the doors of injustice and what we think we've always known to welcome the waves of BIPOC community members who are long COVID and ME patients who are desperate for answers, alternatives, and assistance. Rhetoric is just a dry attempt to placate if there is no action behind it. Today, for instance, I had to appeal an abhorrent decision from Baltimore City Public Schools to not renew my teaching position while I'm still receiving disability benefits I earned and I work for. Workforces can choose now to not just read the governance from the HHS, CDC, WHO, or the NIH. They can actually rewrite history to include the disabled and disenfranchised. right now. It is within our reach, but how far and how long do our arms stretch when it doesn't encompass us or the values that we held prior to the introduction of COVID? Thank you.
Thank you so much, Shamir, and thank you for continually sharing your story.
Thank you.
So many people can feel the same way of just not wanting to just having to continually express this experience, but it's so important, and we really appreciate it.
Thank you so much.
So our next speaker is Dr. Jennifer Curtin. Dr. Curtin is a clinician at the Center for Complex Chronic Diseases, which treats many of the chronic illnesses facing the long COVID community, including MECFS, dysautonomia, and MCAS. She is also the co-founder of Rhythm, which is a telehealth clinic for long COVID. So thank you for being here today, Dr. Curtin.
Thank you for having me. So I just wanted to start by talking a little bit about long COVID and a little bit more about the connection between long COVID and MECFS and some of the other conditions that Adrian just mentioned. So long COVID, as many of you are probably well aware, is defined by the persistence or development of new symptoms lasting 4 weeks or longer past the onset of acute COVID-19 infection. MECFS is a condition that 80% of the cases are typically after an infectious onset, many of which are virally triggered. And it's defined symptomatically by the presence of severe disabling fatigue and something called post-exertional malaise, which is a worsening of symptoms, not just of fatigue, but of other symptoms as well, after any kind of exertion, be it physical or even cognitive exertion. And sometimes patients refer to these post-exertional malaise episodes as a crash because it's very severe, and many times patients can be even bedbound for anywhere from days to sometimes even months in some cases. It's a very severe condition. And other components of this disease are also cognitive complaints. Colloquially, people call it brain fog, unrefreshing sleep, and frequently also orthostatic symptoms. And many people also are, they have a hypersensitivity to sensory input like sound or light, as well as also taste and smell. And sometimes even just exposure to strong smells can send people into this post-exertional flare. And one of the major issues is that MECFS has come on after waves of infectious illnesses and outbreaks throughout history. And long COVID is proving to be very similar. Obviously, long COVID has impacted a vast number of people, and it has been in the press and on people's minds. But MECFS has really been around for a long time, and there's so much that we can learn from the work that has been done in MECFS and these patients' journeys to help address the way that we approach long COVID and how we study it and how we treat it. There are many conditions that are very common in MECFS, such as postural orthostatic tachycardia syndrome, or POTS. This is a condition where when someone goes from lying down to standing or sitting, their heart rate goes up a significant amount, 30 beats a minute or more, which is pretty significant, or their absolute heart rate goes above 120 beats a minute while they're upright. And for some patients with this condition, they may just try to walk across their room and their heart rate goes up to like 160. So for them, it feels like they're running a marathon just walking across their living room. And you can imagine how debilitating that can be. Additionally, there are studies that show that when you have this, as well as MECFS, even without the heart rate changes, the blood flow to your brain actually drops a significant fraction, almost 25%. And so your brain is kind of like running on fumes. And so you can have cognitive disturbances and difficulty processing information. And interestingly enough, this condition is also showing up a lot in long COVID. For those of us with an MECFS background who've been managing this condition for a long time, this wasn't surprising to us at all. And quite a few people with long COVID are developing POTS and other forms of dysautonomia. Similarly, mast cell activation syndrome is also a very common comorbidity in chronic fatigue syndrome and is also showing up in the long COVID community as well. And mast cells are, and this is mast like M-A-S-T, mast of a ship, they're the cells that we think of when we think of allergies. So these cells are really incredible, actually, and they can release hundreds of different chemicals when they're exposed to certain triggers. And depending on where they are in your body and what chemicals they're releasing at any given time, your symptoms can be very different. So they can range from your standard allergic reaction type symptoms like, burning your itchy mouth, swelling in your tongue, difficulty breathing, wheezing. You can have vomiting, diarrhea, low blood pressure, rashes, hives. The list goes on and it can vary. So it's a pretty tricky condition to pick up sometimes. And oftentimes people with long COVID are reporting that they're having either worsening of pre-existing allergies or significant development of new onset allergies that they never had before. And some may feel like they're just reacting to everything, like nothing is safe, everything they're eating. They're trying to find patterns and they're like, there is no pattern. It just seems to be whatever I eat or touch or exposed to, I react to. This is something that is definitely not unfamiliar to those of us who have come from an ME/CFS background. Additionally, Epstein-Barr virus reactivation has been shown in long COVID, and this has been something that has been very well understood and known in the ME/CFS community. And there have been many providers who have actually done the Dr. Lerner protocol where using antivirals, and there's a trial ongoing using antivirals, I believe actually in fibromyalgia currently. Fibromyalgia is also a condition that exists comorbidly with ME/CFS. And interestingly, there's a linking factor between these two conditions called small fiber neuropathy. Many providers, we learn about small fiber neuropathy in our training in the context of like diabetes, where you get this burning pain or numbness. However, it can also affect the fibers that control your autonomic regulation. So these fibers, if they're damaged, can mean that you have swings in blood pressure or swings in heart rate. Sometimes that can even show up as a dysautonomia or POTS. But it can also present as pretty significant pain. Small fiber neuropathy has also been documented in long COVID and sometimes even after vaccination for COVID. Additionally as well, there are some conditions that involve the connective tissue. So like Ehlers-Danlos syndrome or joint hypermobility spectrum, where the joints are hypermobile. They can pop out very easily. People are unusually flexible. And these conditions are very common comorbidly in ME/CFS. And also it's starting to look like this is also showing up in long COVID. So as you can see, there's a big overlap between a lot of these, not just the comorbid conditions, but just ME/CFS and long COVID itself. There are definite differences. However, there's so much that we can learn from both conditions where we don't need to be starting from scratch approaching long COVID. One of the big issues is that many of these conditions that I've mentioned, they are not really well taught in medical school or medical training. If you're taught them at all, it's typically in a fellowship of some kind where you do specialized training in one of these areas. So there may be specialists out there who can manage one of these conditions, but you really need primary care doctors and the generalist practitioners, the internists, the family medicine physicians, the pediatricians, to understand how all of these link together. Because when you've got something that's impacting all of these systems, you may get referred to a neurologist, an allergist, cardiologist, but they may see kind of the one section and not really be able to put it all together. And that's really what these patients need. And so, one of the ways that addressing this provider shortage, there's a lot to learn. The learning curve is extremely steep to be able to put all of this together and to do it well. And so that's something that is so desperately needed. So just, because the need is so great, and I've seen the wait list at my clinic grow to like 10 months long, and some of the long COVID clinics have wait lists that are so long. I started this company Rhythm to basically provide telehealth care and create a decision support tool to try and help onboard providers so they can learn this complex management more quickly. And also so that we can start mapping out this management so that it can improve with time. So as we get more data from the patients that we're treating, it can actually inform the algorithm so it gets smarter over time. And that way, all of the treatment of these patients isn't, lost in the ether. It can be passed on and more effectively utilized by providers to come. So, I put this out there to everyone. I had ME/CFS for 9 years myself. The disease is horrible. And with so many more people now developing ME in the wake of COVID-19, there was already such a provider shortage for ME before COVID. Now that is even strained even further. And really, this is an opportunity for all of the medical community to really invest in and learn about these post-infectious type conditions that have been around for a long time. We just haven't prepared well enough for them. And now we're seeing how that is essentially overloading and crippling the system and hurting so many people. So now is really the time that we need to really get on this problem so that we're prepared, not just for what's happening now and what will continue to happen after every wave of COVID, every new variant that rips through, we're going to get a wave of long COVID after that. And there are studies showing that as many as half of long COVID patients are meeting the diagnostic criteria for ME/CFS. So this is a big deal, but also COVID will not be the last pandemic that we face as a society. So we need to really invest in this and move forward, starting now.
Thank you so much, Dr. Curtin, for all of that information. Our next speaker is Ben Hoosberger, our Advocacy Director for MEAction. He has been on the front lines of advocacy work since 2016, calling for our government to address the crisis of ME/CFS. His work now also focuses on the long COVID crisis, in particular the NIH's Recover program for long COVID research. Thank you, Ben.
Thanks, Adrienne. And thank you, Dr. Curtin. That was a great overview. So I think the one main, Jennifer spoke well to the connection between ME/CFS and long COVID and all the foundation of the things that we know from those things that can build a foundation for treating and dealing with people with long COVID. And from an advocate perspective, one thing that has been true for ME/CFS groups like MEAction, as well as many other long COVID groups have repeatedly called for, is for us to build upon that foundation. There's a foundation of post-viral, post-infectious onset illness research that's out there. We should be using that and building upon that to inform our research strategies for long COVID. And I think Linda will speak to a lot of that later too as well. But as an advocate, that's really important that we see. As an advocate, one of the other things I just see frequently, particularly in coverage and replies from the government, is the admission that there are a few answers for people living with long COVID right now. And I think the key question to be asked is, why are there so few answers? There's a foundation to be built on, but I think all of us would acknowledge there's nowhere near what there needs to be in terms of support and treatment and care for people with long COVID. And from an advocacy perspective, what MEAction is seeing, there's really no justification for why we currently have so few answers, treatments, or support services available for people with long COVID right now. That reality is a result of our government's decision, previous decisions they've made not to be ready and not to take steps to deal with the crisis when people with ME have brought this and called on action for years. And if you go back and look year after year of agency report, keeps redescribing the problem that has been known about how ME/CFS is a serious problem that needs to be addressed. And yet there has still been a lack of commitments, plan, or accountability to do anything to adequately resolve it. In fact, one of the most recent reports was released by NIH at the end of 2019 for ME/CFS, and we pointed it out again at the time. It was yet another report that just redescribed the problem with no plan, no funding, no timeline or accountability to deliver the outcomes for patients. So when we ask why, when we look at this situation that exists right now, this has really been a situation for lack of preparing. Post-viral and post-infectious complex chronic illness is not a new thing, but our government, our medical system hasn't been prepared to adequately deal with the crisis that existed pre-COVID, let alone now the surge we are seeing now. With ME/CFS onset, A recent study that came out estimated that the economic impact just of MECFS onset from the COVID-19 surge will have brought will be between 150 to $360 billion, and that's just for the MECFS onset. And so that's why ME advocates have launched really the Millions Missing movement, and we've been protesting for years for lack of government action, trying to bring awareness to how many people are impacted by this disease. The Millions Missing movement has been happened in over 100 cities worldwide before COVID-19, and this year again we'll also be trying to uplift virtually the stories of people personally impacted, and partnering with the long COVID community to do that. But for years NIH has one of the reasons we've had so few answers is because for decades MECFS has been one of the most underfunded diseases in NIH's portfolio. So prior decisions have put us in the situation we are now. So we need to make different decisions. We need to acknowledge the history, and then we need to make different decisions to break with the past. And part of that also means that MECFS research needs to be part. The MECFS needs to be part of the long COVID response that the Biden government administration has announced. There needs to be a whole of government response. It needs to be coordinated in an interagency approach. And that means looking at things that, particularly patients identify, like how do we expedite treatment outcomes for people with long COVID now to get early intervention for people. And so there are currently repurposed drugs that have been used for treating people with MECFS. How can we expedite clinical trials for those people now to see what can work? To get treatment and support to people now. And I won't take up too much more time, but I want to kind of underscore that the reason people are suffering so much is not just because there's a new disease, new problem, it's because lack of government response and attention to people living with complex chronic illness. That's been a pattern that we now need to break. So I thank you very much for your time and look forward for everybody else's contribution. Thanks. So I'll pass it back to you, Adrienne.
Thank you so much, Ben, and thank you for contextualizing the problem for us. So our next speaker is Linda Tannenbaum. Linda is the CEO and president of the Open Medicine Foundation. The Open Medicine Foundation is the largest private research organization for complex diseases like MECFS. OMF is currently supporting 6 research centers across 4 countries and on 3 continents. We are excited to have Linda here today to talk about the work that Open Medicine Foundation is doing to research MECFS and long COVID. So thank you so much for being here today, Linda.
Yeah, thank you very much. Yeah, thank you, Adrienne. And thank you to the speakers who really show not only the passion of what needs to be done, but brings it all together, because we've been in MECFS community for many years in what we're doing, and we'll get into that in a minute. But now with long COVID, it is just magnifying and exponentially growing how important this is to for treating patients and for allowing access for everybody to be able to get care and improve their care. We all have to do something. So I got into this myself, which was very personal in 2006, when my 16-year-old daughter was suddenly so sick that she could no longer get out of bed. And she had to quit school and her life just stopped. And again, long COVID people can relate to everything that we're going to say here about MECFS, because it's really the same story. She was perfectly fine when I dropped her off at school that day. And 20 minutes later, she was sick enough to go to the ER and ended up bedridden. And she was 16. She was just starting 11th grade. The experience at that time was seeing over 20 different doctors over a course of a year and ending up with no answers and leaving us totally hopeless. She was eventually diagnosed with something they called at the time chronic fatigue syndrome, which now you hear we call MECFS or ME. And it gave us a name and a diagnosis, but many more questions than answered. And I soon found out that there was no way to diagnose this except by exclusion. And there were no treatments except pain management, which didn't work at all at the time. And apparently my daughter was not the only 16-year-old debilitated by this disease. I learned that many adolescents and millions of people all over the world were also suffering with no answers in sight And now it's just growing exponentially, like we talked about with long COVID, with kids and adults and adolescents alone, and people having to leave school and having to leave work and having to leave their lives, unbeknownst to them that this was going to happen when they just had maybe even a mild COVID infection. At the time that my daughter got sick, there was very little ME/CFS research taking place, and there was no hope for anything that would help my daughter. So I had to do something. So I jumped on an opportunity to connect with a few researchers who were looking at this disease. And I'm saying a few researchers at that time. But realizing there was no money at all for these researchers to do anything, I set up Open Medicine Foundation to see if I could raise money and help facilitate this research and connect to the ME/CFS community, really to bring them hope that something was happening after so many years of people being sick. So OMF, as we call it for short, was set up in 2012. And now we're 10 years out. And we have connections to people in way over 100 countries. And as Adrian said, we established and we support 6 collaborative research centers at top universities in 4 countries and 3 continents. And we have a highly credentialed 19-member scientific advisory board that includes 2 Nobel laureates and 6 members of the Academy of Sciences. We're trying to find answers as quick as possible. We've raised over $36 million in the last 10 years, and we funded over 40 different research projects for ME/CFS and related diseases, what we now refer to as multi-system chronic complex diseases, little m, little s, capital C, capital D, which now includes long COVID, sadly, as well. So I guess you want me to kind of go into and continue talking about how we included long COVID? I'll do that. So as soon as we heard about COVID-19 in 2020, we knew that this virus would likely lead to chronic conditions, as we've seen with other viruses, the Epstein-Barr virus triggering ME/CFS in many, many cases. We immediately applied and received a $1 million private grant and started to follow people with positive COVID-19. We began a large-scale international collaborative study to find the biological differences between the people who return to good health and those who remain sick over 6 months, those that we now call long COVID and several other names that you've probably heard of. We know that ME/CFS can be triggered by a viral infection, and the growing number of people with long COVID are now developing similar chronic symptoms as ME/CFS, as you've heard, adding millions of more people that really are their lives have stopped. And so now we're also adding ourselves, we have got ourselves together to partner up with the Bateman Horne Center. And the Bateman Horne Center is the primary driver of provider and patient educational resources for ME/CFS and fibromyalgia, and now long COVID. And to make it simple, there are just not enough clinicians to go around, as you've heard. I mean, so many people that had ME/CFS and have ME/CFS have nowhere to go. And now with long COVID, the primary physicians really don't know what to do with the patients. And the patients barely are even validated that they're sick, that this is a real disease. Maybe they only had mild or moderate COVID. And the doctors are saying, that's not what this is. There's something else wrong with you. Well, the truth is it is a biological disease, and we have proven it over and over again with the research that we have done. So now what we're doing is we're really taking on a medical education push to really try to educate as many health professionals as we possibly can to not only expand awareness and knowledge, but to help with diagnosis and treatment of what we've already learned from ME/CFS. So we hope in the medical community that we can teach more and train the doctors to recognize these diseases, to at least help reduce the symptoms. And then on the research side, to learn what we've already learned from ME/CFS and help the long COVID community get a jump start on the research that's happening and not starts from scratch. So we thank you all for helping us increase awareness as much as possible to the community out there, to the community at large, and to everyone who's suffering, to let them know that something is happening so we can help them and so they don't have a future of sickness and return to good health. So thank you very much. Appreciate it.
Thank you so much, Linda. Thank you for all of the work that Open Medicine Foundation is doing. It's been incredibly important to the ME community and now to the long COVID community as well. So we're gonna open it up for question and answers in just a few minutes. I just want to circle back around to Ben again to give us some closing remarks.
Okay, and so so thank you all. I will be brief. Appreciate what everybody said. I think one of the main takeaways I would just like reemphasize to people is that there is, though we face a very, very large challenge with staggering numbers of people being affected, there is a base of knowledge that we can turn to. There is practice and experience from dedicated clinicians doing this work, treating people that we need to be uplifting. There has been important and critical research work that has been spearheaded and pioneered, like Linda talked about with OMF for the past decade on some of these things. We need to make sure that work is at the forefront leading this response. And what we need to see is a whole of government response that takes this seriously. There are too many people falling through the cracks. And like the only way to understand and identify where those problems are is to talk to the people experiencing them. So if you don't, so the way you make sure, the issues of discrimination, of denial, disability benefits, all the different ways that people can get lost in the system. The way advocates want to see that addressed and applied is to listen to the people experiencing it. And that's what MEAction is fighting for. That's what Millions Missing is about elevating and showing the common thread that runs through all of these stories, whether you have ME/CFS or mast cell activation syndrome, dysautonomia, some other diagnosis, the experience within the system that people are having. And so we need a new and a different system that listens and centers our voices to create a new society. So thank you, Adrienne.
Thank you. Thank you again, everyone. And so yes, if any of the journalists on the call today have questions, go ahead. You can go ahead and raise your hand or type it into the chat. Now's the time if you would like to have panelists speak more to a question. Okay, so we have a question from Miriam Tucker. She says, have the rates of long COVID subsided since the COVID vaccine became widely available? Dr. Curtin, I wonder if you could speak to that question, if how the vaccine is affecting long COVID.
So, depending the vaccine, it does seem like from at least the studies are somewhat mixed, but it seems like vaccination does seem to reduce the risk of long COVID. As shown by one study that's available. There's another that showed that there wasn't really an impact on the vaccines on your risk of developing long COVID. And so, it's a little bit hard to say. There's also a difference too with just the different variants because some of them seem to be escaping the vaccine related immunity to a greater degree than others. And so the vaccines are going to have somewhat uneven protection depending on which variant and which wave you're talking about as well.
Great, thank you. Okay, so we had a question emailed to us from a journalist who's going to be watching later, who wanted to know, how can primary care physicians handle the amount of individuals with a new diagnosis, with the new diagnoses that are happening? Dr. Curtin, that might be a good one for you as well. And I don't know if anyone else wants to address the question as well. Feel free.
I'd like to address it as well as after Dr. Curtin. I have some thoughts about it as I've recently had some experience with my PCP as it relates to long COVID.
Great, thank you.
Yeah, so I'll kind of take this more from just like kind of the, where you can kind of go for resources to understand more about long COVID. So, the CDC does have some information there. The other thing is the MEACFS Clinicians Coalition website has a lot of really good information. Open Medicine Foundation has great information as well. Bateman Horn Center has a lot of information. And the ECHO program, they're doing a series on long COVID that occurs. There's a meeting monthly where you can, it's designed for primary care providers to learn in kind of a group setting. And you can go over different cases and things that you're having trouble with. And additionally to, at least like, that's why one of the things I'm working on with Rhythm is building a decision support tool for this, because it is not easy, so.
Thank you.
Thank you, Dr. Curtin. I think it's so imperative that first of all, as it relates to how primary care physicians can truly handle the influx of patients is to remember that ME and long COVID, the conditions are patient-centered, informed conditions. And so listening to the patient is going to be the key in helping those doctors deal with the vast number of people who will be knocking on their doors and making appointments to be treated for long COVID and ME. I think that doctors can definitely start to as Dr. Kern mentioned, start to make smarter decisions, or let me not say smarter, wiser decisions, or more informed or compassionate decisions, because there is guidance from the CDC, WHO, the World Health Organization, the NIH. There is a lot of research that is being produced and written and published every single day that speaks to the condition of long COVID and ME. And so I think that we first have to start listening to the patients, making wise decisions, decisions that are informed based upon symptoms, as well as diagnosing patients. The fight that I'm having as a patient now is I am in a battle, another battle, battling with my primary care physician to get her to diagnose me using an ICD-10 code that represents long COVID. Having that code will, and using that code going forward will assure that I maintain my health benefits, it maintains my, disability benefits, as well as any, if there's government action that's supposed to take place for long COVID patients, which will also include ME patients, it'll make sure that we are able to obtain earned and governmental benefits. And so I think that the first thing doctors can do is listen, be compassionate, and don't be afraid to take the risk to diagnose. Because as Jennifer said, once there's a tool that can, and my doctor said, recently, she said as she was looking over mast cell activation, she said, Johns Hopkins has given us a cheat sheet. So right there lets us know that doctors are being informed about how to treat long COVID. Whether they use those tools or not is going to be the difference between handling an influx of patients poorly or handling an influx of patients with compassion, empathy, and a sense of management. Because many of us are not expecting that our doctors have all of these immediate answers. We're just hoping and praying that doctors are able to help us manage. And I think that's going to be the successful key to assuring that all of the thousands of people who will need primary care physicians' assistance will be helped and treated as best as they can be.
Thank you, Shamir. That's such an important point in terms of just helping the patients who, even just getting that diagnosis on the chart is huge. So thank you for speaking to that.
Adrian?
Yeah, go ahead, Ben.
Oh, if we have time for this, I would just kind of flag one other thing, and maybe some of the other speakers, I think, could each contribute to some of this. One of that points that I'd just like to make is that, for some people like myself, or maybe even Shamir, who have a very acute, immediate onset of 17 years ago, I got a virus. I immediately got sick, and it was a very black and white situation before and after. I was able to tell a very clear story, even though even though a lot of doctors didn't listen to me and I wasn't able to find a lot of treatment benefits, I was at least able to tell a very clear story about what happened. And even though the majority of people with ME/CFS are often have a viral onset, I think it's important to acknowledge that within this community of the sick with complex chronic conditions, some of us have multiple triggers for things and incur not just one onset to something, but multiple ones, or may go back and forth. And so I think there needs to be space when we tell these stories for all of those. And I think that's, one of the things I've been it's been so important to see a lot of the long COVID groups push on is the importance of that simply having a positive, you should not require a positive test, a COVID test for for having long COVID. And so, and to think about this, the need for an integrated response of ME/CFS and long COVID, and that if we have, someone might have, and some of the doctors and researchers on this call can speak better to this than I can, but to have, your body may be affected by getting COVID-19, but it might be a future then layered on onset trigger after that maybe triggers newer complications that become more clearly revealed. And so like the bottom line I'm concerned about as an advocate is that our government, our society, our medical institutions commit to people who have complex chronic illnesses, get the treatment and supports they need, and that we stop, making only certain people with certain stories who get believed for certain reasons get the treatment and access they need. And I think that's really important, both from a scientific experience, that like, this is not the way chronic complex conditions work, that like, there's just like one cause and one effect, and it's very clear. And also people's individual experiences within our society and the discrimination and the structures that are there get very different experiences. And so we need to make sure that when we're looking at responding to this, we include everybody and nobody gets left out.
Thank you, Ben. That's such an important point. So I'm so grateful today to all the panelists who shared their experience and knowledge and time with us. And thank you to the journalists who have come. If you need any follow-up questions, feel free to reach out to me if you need any follow-up information. And thank you everyone also who is watching the recording of the video. I know there was a lot of journalists who weren't able to make it, but had asked for a recording. So thank you again. And I will put my email address in the chat in case there are follow-up questions from journalists. But thank you for your time.
Thank you. Good to see you all. Thank you all for your work.
Thank you all.
Yep. Thanks, everyone.
Thank you.